We're now going to move on to ACS, and Chris is going to take the floor to lead us on to Twilight.
Great, thank you. So this is an interesting study, and it first got presented just under a year ago at TCT. But there's been multiple sub-studies released since then at sequential meetings, and there was more information on it at ESC. So this is basically a de-escalation strategy from DAPT after PCI. But instead of getting rid of the P2Y12, the theory here is get rid of the aspirin and go on to ticagrelor. So let's talk through it. If we think about what we do at the moment, we've had this strategy of always thinking aspirin's indispensable. You know, aspirin's the bedrock, and then you add and take away the other drugs on top of it. And here are our Cardiac Society guidelines. They tell us that we should continue aspirin indefinitely, and we give DAPT after PCI or ACS for 12 months. And there's a strong bedrock to that. Let's not forget the evidence we have from trials such as Plato, which shows that there's a significant reduction in events by dual antiplatelet therapy with strong agents like ticagrelor. Big study, 18,000 patients, and indeed significant reduction in MI and in vascular death compared to clopidogrel. So there's no doubt that these dual antiplatelet therapy with potent agents work. Let's not give up that evidence. But let's think about the downside. We know there's a bleeding cost to it. And we have, of course, a number of studies that now are looking at relatively low-risk patients and modern drug-eluting stents, saying they're relatively safe from a stent thrombosis perspective, and are looking at de-escalation with various strategies, taking away the dual antiplatelet therapy early, 6 months, 3 months, even 1 month in some studies. But we have to be cautious. We have to remember that stable coronary disease and stenting is different to ACS. And indeed, we have some signals, including from those landmark studies with the ongoing separation of the curves, but also from studies like this SMART date, which looked at stopping your clopidogrel at 6 months compared to 12 months. And they showed, to their surprise, a significant step up in adverse events in MI in the group who stopped clopidogrel early. So perhaps de-escalating to aspirin in higher risk patients like ACS is not a good strategy. But what about going the other way? What about stopping the aspirin and continuing a potent antiplatelet agent like ticagrelor instead? This is a highly attractive option because ticagrelor is very effective at platelet inhibition, and perhaps adding on the aspirin doesn't add too much to ticagrelor. So Twilight looked at that, and it was essentially a study where you included people with some high-risk criteria who are having PCI, either clinical criteria such as old age or ACS, or angiographic criteria that put them at a higher stent risk, such as multivessel CAD, left main bifurcation lesions. And so you randomized those patients, you gave them a lead-in period of DAPT for 3 months, and if they tolerated that without problems, then they were randomized to either continue on with DAPT for another 12 months, which is essentially standard of care, or de-escalating back to just ticagrelor as single antiplatelet strategy. Their main endpoint was bleeding, and they used various definitions of that, and they had a key secondary endpoint, of course, of safety, looking to see whether there was any increase in ischemic symptoms by getting rid of the aspirin. The primary endpoint, not unexpectedly, if you take away one of the antiplatelets, you significantly reduce bleeding, and that was true for moderate degrees of bleeding like BARC 2, but also for serious bleeding, BARC 3 or 5 category. But what was most pleasing was there wasn't any signal of ischemic risk, so there wasn't any increase in heart attack, death or MI or stroke, so the usual MACE criteria. So it seemed to be a safe strategy with reduction in bleeding and no ischemic cost. But of course, this was a mixed bag of patients. Some had stable disease, some had ACS, and they're not at all the same entity. So it's important to focus on higher risk groups like the ACS. And this was presented subsequently at the AHA meeting at the end of last year. And again, taking away the antiplatelet, taking away the aspirin, significantly reduced bleeding. In fact, the separation was much greater in this higher risk group. But again, there was no ischemic cost, so there was no increase in MACE by reducing by de-escalating back to ticagrelor alone. Maybe most importantly, the complexity of the coronary disease is something that interventional cardiologists will be most worried about, and that was addressed earlier this year in the complex study. So basically, they took patients who had complex PCI, and this is a well-recognised group of patients now. They're characterised as multi-vessel disease, multi-lesions, very long stents, bifurcations, etc. And the importance of these criteria, they got derived from previous studies de-escalating to aspirin, and these criteria were found to be the criteria that meant that was an adverse strategy that had an increased event rates when you de-escalated that too early. So it's of great interest to see whether the same happens when you de-escalate to ticagrelor instead of backstepping to aspirin alone. And I won't show the bleeding because that's obvious, that reduced, but importantly, the ischemic endpoints weren't affected by going back to ticagrelor. In fact, if anything, there was a trend towards slightly better safety in terms of MACE by ticagrelor monotherapy. Finally, at ESC this year, we looked at the chronic kidney disease patients, and as Phil has said, these are much greater group of patients in terms of risk and complexity. And in short, we found that those patients with chronic kidney disease compared to patients with normal kidney function had a significant increase in bleeding risk, which was greatly ameliorated by stepping back to ticagrelor alone. And again, no ischemic cost by doing that. So across the board, whichever subgroup you look at, it really suggests that the strategy of stepping back to ticagrelor is safe and effective with greatly reduced bleeding. This isn't the only study that looked at this strategy. We've had two other studies look at it. Global Leaders was presented 2 years ago at ESC. Although it was a complex study with a very mixed bag of patients, stable, ACS, and they went for 2 years, which mixes de-escalation and escalation of therapy when you think about the fact you're going from aspirin to ticagrelor after 1 year. Even with all those caveats, there was a strong signal towards benefit, and that's borne out if you focus on the most important patients, the ACS within the first year. The TICO study specifically looked at ACS patients. This is a smaller study of about 3,000 patients, and again, step back to ticagrelor alone at 3 months. Same signal again, less bleeding, no ischemic cost, perhaps even an ischemic benefit by doing that. So I pose a question for discussion at the end of the session. The evidence is starting to mount up, and should this actually be the new standard of care? It's not something we can do at the moment. We don't have approval to use it as monotherapy in Australia, but maybe we should start pushing for that on the basis of this evidence.
Thanks, Chris. We'll come back to that in the discussion. So I'm going now to ask Steve Nichols to talk to us about the important trial, partly because it's an Australian trial, but it also has a very interesting result. So, Steve, low dose.
Thanks, Phil. Good evening, everybody. ESC saw the latest instalment in what's become a fascinating story about colchicine and a nice way of repurposing a drug to target arterial wall inflammation and potentially be a cardioprotective therapy. And we saw early data from Western Australia in the Lodoco study. Small number of patients show potential benefit. Last year at the AHA, we saw the Montreal Heart Institute report the findings of Colcott over 3,000 patients and saw cardiovascular benefit, interestingly predominantly driven by a greater signal in terms of stroke reduction. And now you see at ESC the results of the LODOCO-2 study, a study which evaluated the effects of 0.5 milligrams daily of colchicine on cardiovascular endpoints in patients with chronic coronary disease. This is a study that was, again, run by the Western Australian group. It was started in Australia. They expanded to include a number of Dutch sites in a study of a little over 5,000 patients. As you can see, they were patients between the ages of 35 and 82. They were clinically stable, having had their clinically manifest coronary index event at least 6 months ago. All patients underwent a 30-day open label run-in period of 0.5 milligrams of colchicine. And then you can see after that, those who were tolerant to the run-in period and clinically stable and willing to participate were randomized to colchicine or placebo, with the idea that all patients would be treated for at least 12 months after the last participant was enrolled. Important numbers here. They enrolled a little over 6,500 patients. About 9% of patients did not tolerate that open label run-in period. 55-22 were randomized, treated for a median of 29 months. Again, about 10% of patients in both treatment groups came off study drug during the trial, which really isn't that bad. And they had extraordinarily outstanding clinical follow-up. They had endpoint status known for all but one patient, which was a fantastic result. Here are the baseline characteristics. Mean age 65, a lot of risk factors. Somewhat disappointingly, 85% of enrolled patients were male. I know the investigators were frustrated by that, but I think it really tells us we need to continue to do better in clinical trials moving forward. More than 80% of patients had had a prior ACS. 2/3 of those had been more than 24 months ago. So the majority of these patients had very stable chronic coronary disease, very well treated, high rate of use of antiplatelet agents, statin therapy, and other proven anti-atherosclerotic and cardioprotective therapies. Here is the primary endpoint: combination of cardiovascular death, MI, ischemic stroke, and ischemic-driven coronary revascularization. You see a hazard ratio of 0.69 in favour of colchicine, with the curves really separating probably at about 5 or 6 months. And it really is a really impressive result that, again, really strengthens the story for colchicine as a secondary prevention agent. What if we look at the kind of key triple MACE, cardiovascular death, MI, and stroke? Hazard ratio 0.72 again, so a very good result. And then when you looked at a range of pre-specified secondary endpoints, you saw a very consistent finding, whether you looked at cardiovascular or cardiac events, whether you looked at revascularization or myocardial infarction by itself, all very impressive hazard ratios and a significant p-value. Again, less ischemic stroke, small number of events not achieving statistical significance. Interestingly, you saw a greater numerical number of deaths when you looked at that ranked secondary endpoint kind of data. Here are the pre-specified subgroups. And again, I think you see a few lines that cross one, and immediately you think to yourself that probably doesn't really kind of mean too much. It looked like the drug largely worked in everybody, except there is one interesting finding at the bottom, and that is that there seemed to be a statistical difference in the treatment effect seen in the patients treated in Australia compared to the patients treated in the Netherlands. A much more robust treatment effect was seen in the patients in Australia. Whether that reflected a lot of those patients may have been treated for longer. There are some differences between the two groups. Interestingly, in the New England Journal, it was reported as, when examined according to the effect of colchicine, that the primary endpoint was directionally similar, but appeared to be quantitatively larger in Australia. I'm not entirely sure that that's quite correct, but I think as an Australian, I feel somewhat fortunate that we're on the right end of the fence in terms of the effect of the drug. In terms of looking at serious adverse events, there is an excess of non-cardiovascular death, 53 versus 35. That was not seen in the Colcott study. There's when you look at the individual kind of causes of non-cardiovascular death, there's no real individual signal that comes up. So that's a confusing signal that I think needs to be understood to a greater degree. Otherwise, kind of safety looked pretty good. And so the summary for the LDOCO-2 study was for patients with chronic coronary disease, low-dose colchicine reduced the risk of primary composite endpoint, a number of key secondary kind of endpoints, and in general appeared to be well tolerated and appeared safe, although I think this kind of non-cardiovascular death signal has certainly kind of received a little bit of attention in the last few days. Just a few additional kind of results just worth kind of commenting on. The Dutch collaborators in this study reported in Circulation 2 days ago a proteomic study of samples taken during that run-in period with colchicine and showed a reduction in a range of inflammatory markers. And I think it starts to kind of give us some sense for the mechanistic studies that are kind of may reveal some information in terms of trying to understand why colchicine is cardioprotective. And then finally, I think it's important to also acknowledge a really important result by Victorian colleagues looking at the COPS study, and this was a report by David Tong, Jamie Leyland, and a range of colleagues in Victoria, where they took 800 patients. They enrolled patients to treatment for just a little over 12 months after an acute coronary syndrome with colchicine or placebo. And you see that they just failed to meet statistical significance in terms of the primary composite endpoint. In fact, if you look at the Kaplan-Meier curves, a non-pre-specified analysis, when they took the non-CV deaths out, it did appear to be that there might potentially be a benefit, and suggesting there might be earlier benefit. And that's certainly consistent with some of the reports that the Colcott investigators reported. The only other point that I would kind of highlight from this study is that in that study, they also saw imbalance in deaths. They saw more cardiovascular deaths, 3 versus 1, more in the colchicine group, but they saw 5 versus 0 non-cardiovascular deaths, very small numbers, and imbalance. And in its own, you probably think, okay, maybe that's not that big a deal. But when you've seen the signal in LDOCO, I think that as we try to kind of understand the net clinical benefit here, I think a lot of people are going to want to know a little bit more information. On that note, thank you, and I think I'm passing on to Derek Chu.
Colchicine may fit in at the end. I'll hand over to Derek now, and he's going to talk on 3 subjects, a couple of trials, and the new and non-STEMI guideline. Derek.
A few trials to quickly report on. The first one, I'm just trying to make sure that I can move these slides along. Is that going to work? No, I won't be able to do it. So just give us 1 second. There we go. So the first trial I have to report on is the E2P PCI study. This was a study of trimetazine. This is an agent that changes myocardial metabolism, shifting to glucose metabolism to decrease myocardial ischemia. And it really has shown no benefit. This was a study of patients who had actually already received PCI, and their initial planning was that there was a significant proportion of patients that still get angina. This agent, you can see clearly well overlapped lines, no benefit, no adverse events in this group of patients either. So I think that this agent's probably not got a lot future here in Australia for us, and I'm just going to move on then. The next study was really the popular TAVI trial. This is the cohort A group that looked at aspirin alone versus aspirin clopidogrel in patients receiving a transcatheter heart valve. The practice here has been just grafted over from stenting. That, you know, the rationale is basically that TAVI is just a big coronary stent put in the aortic valve. So the use of clopidogrel in combination with aspirin has sort of been just extended over to this practice without any formal evaluation. So this is the first formal evaluation of this, a randomized study that randomized two groups. Sorry, I'm just having trouble with the slide things. Two groups, aspirin alone versus aspirin clopidogrel for at least 3 months. And not a huge study, but really the event rate in this population is relatively high, and therefore you could get an answer in about 700 patients. So the primary endpoint was all-cause bleeding, and you can see that all-cause bleeding was lower in those receiving aspirin alone, almost a halving of the risk of bleeding events. And you can see that there was no significant difference out to a year for the ischemic endpoint of cardiovascular mortality, ischemic stroke, and myocardial infarction. If you combine those two together, you see that there's still an overall benefit with an aspirin alone strategy. And so I think that practice will relatively quickly evolve. There is an ongoing study looking at the combination of NOACs and clopidogrel and or aspirin in patients who have an indication for the NOACs, but we don't have the result of that yet. I'm going to move over to the ESC guidelines, and this is an extensive document, 75 pages of some old and some new content. And I thought I would just try and skip through some of the newer content that that has been sort of has found its way into the guidelines. Some of it I think is a little contentious, and so potentially we can discuss the ones that might be a little contentious to Australian practice. So I apologize for, it's just easier to give you sort of the screenshots of the document, but I'll skip through the things that are somewhat more relevant to us. As a lot of Australia is now using high-sensitivity troponins, the Europeans have embraced a 1 hour protocol. They have said it's acceptable to use a 2 hour protocol if you can't operationalize a 1 hour protocol in your institution. The other thing that they have said is that other investigative biomarkers haven't really been embraced at this stage. However, there is a recommendation, I haven't highlighted it here, but there is a recommendation to routinely sample NT-proBNP or BNP in these patients, as it does provide further risk stratification. There's been a shift towards CTCA, as one might expect in the guidelines. So in patients without recurrent pain, normal ECGs, there is a recommendation for further testing, and either by non-invasive imaging or to assess for inducible ischemia or CTCA. And certainly they are stepping away from going towards an invasive approach in the absence of objective ischemia. And there's certainly a push towards CTCA in those patients, again, without evidence of troponin elevation, normal ECG, but low to intermediate risk of coronary artery disease. Again, a recommendation to proceed to CTCA. So, sorry, I've forgotten that I did include this. So here's the recommendation that we routinely measure NT-proBNP or BNP for further risk prognostication. And there's been an interesting shift in the the recommendations around risk scoring. There is a downgrading of the risk scoring for the GRACE score, but there has been the inclusion of risk scoring for use of dual antiplatelet therapies in the longer term. And also the use of risk scoring for bleeding risk scores. Again, there's not a lot of prospective data for the latter two. Obviously, the Australian study is the only one that that has answered the first one with GRACE risk scoring. I didn't really want to walk through each of these things. I just wanted to show the great thing about the ESC guidelines is that they do have I think, very useful and informative graphics and figures that are helpful. There's clearly the guidance to assess clinical risk in the use of anticoagulation, but in fact to stagger that by assessing bleeding risk at the same time. And there's a clear guidance and duration based on that information. So with regards to the pharmacology in patients with non-ST elevation ACS, interestingly, based on ISO React 5, it seems that the Europeans have made a recommendation to prefer prasugrel over ticagrelor. So they've done this off a single study. The other recommendation that might be deemed a little contentious, or at least is a significant change, is that that in patients where the coronary anatomy is not known, that the pre-treatment with a P2Y12 inhibitor is discouraged effectively unless you're undertaking a conservative or a medical management approach, i.e. pre-treatment, which is very commonly practiced in Australia, has been actively discouraged now in these current guidelines. Again, not really wanting to go through it in detail, but there's nice graphics in the guideline to highlight the integration of the newer oral anticoagulants and single or dual antiplatelet therapy, duration of therapy, and choice of therapy, stratified by bleeding risk. And I thought that these graphics were quite useful. So the other interesting documentation in the guidelines was really a section on SCAD. There is a brief section in the text, but a kind of helpful graphic describing the treatment of SCAD based on the angiographic type that one identifies in the lab. Interestingly, there's a recommendation to undertake coronary imaging by IVUS or OCT in those with obstructive but normal flow, and that obviously some of us are concerned that might actually cause non-obstructive disease to become very obstructive. But it is something that that certainly could be considered judiciously. The other addition is a section on myocardial infarction without occluded coronary vessels, so MINOCA. There is a workflow, if you like, that tries to assist in the diagnostic process. It does make relatively strong recommendations about the use of CMR in this. And again, not wanting to work through the whole flow diagram, but highlight the fact that it really has been now recommended that that all patients with suspected MINOCA undergo CMR, which obviously creates some access problems for regions of Australia. So on that note, I thought I would stop, but also highlight the interesting thing about the guidelines is that they do report performance measures, and they do also report nicely a table full of of areas where we need further clinical trials in ACS care. So I actually thought it was quite a good document. I'll stop there, Phil.
Thanks, Derek. If we get Steve and Chris Hammond back on the line, I'm just going to ask each of you to start with just a quick answer, because we are running a bit short of time. Are you going to incorporate colchicine into your routine treatment of either acute or chronic coronary syndromes? Derek, just yes or no?
Yes, but
sorry,
my but is probably that we just need to be careful about that signal of non-cardiac deaths.
Yeah, Chris.
No, I'm very confused. No. The things that benefited in cold cod are very different to what we benefited in Lodoco. So, and the signals for pneumonia and non-cardiac death, I think, need further evaluation.
Okay. Steve, same?
Agree, selective.
Okay.
We need, so there are more trials coming.
Okay. So I think the pre-treatment is what I thought the big issue was in the guidelines. Derek and Chris, you're both interventionalists. Are you going to go next week and tell your ED to stop pre-treating? Chris?
We don't treat the same as Europe. When we look at their studies, they have a mean time of 2 to 4 hours to the cath lab. And in Australia, we've seen repeatedly it's days. So I don't think the same principles necessarily apply in Australia. So I think we will still probably routinely pre-treat unless we're very effective tertiary hospitals with direct presentation.
Derek?
I think in the country, in South Australia, I mean, the transfer rates are high and good. In the country, I have no problem with them pre-treating because it still is, 18 to 24 hours before they get to us. But in the large hospitals, our delays are really short. And I think that the incremental benefit of pre-treatment for those few hours really is diminishing substantially. So I actually favor not pre-treating.
Okay. So a common theme has been cutting out one of the antiplatelet agents. In Twilight, we cut out the aspirin, and in the TAVI, we cut out the clopidogrel. Long way to go. What should we be doing? Do we have single platelets for everything? And if so, should it be aspirin or should it be the best P2Y inhibitor or clopidogrel halfway between? Derek?
I think it depends very much on the prothrombotic environment that we're dealing with. And so in hot acute coronary syndrome, I do think the P2Y12 inhibitors provide an incrementally clear greater benefit, and aspirin for the first 3 months is wise. I think that in stable disease and in TAVI, that's not a hot inflammatory environment that we're dealing with. And so I think the idea that potent antiplatelet therapy is going to provide a substantially incremental ischemic benefit in this group of patients is probably an extension that we interventionalists have made without any evidence.
Chris?
Yeah, I agree. I mean, absolutely right. The other thing to remember is the very low dose antithrombotic. So instead of throwing everything at the platelets, a little bit of therapy for the platelets and a little bit of anticoagulant, as we saw in Compass, may have massive benefits. So we shouldn't forget that strategy as well for the more stable patients.
And
Steve,
actually,
I agree with Derek.
I think there are murmurings that
unfortunately, we're going to have to cut the discussion short to move on. That's so. Thank you very much to Chris, Derek, and Steve.